Hello, I'm Warren Ward, and this lecture is about the inpatient management of eating disorders. The main focus of this lecture will be on the inpatient management of adults, but some of these principles that I lay out will certainly be helpful with the management of younger people. Just a little bit about me and my experience in this area. For about 15 years, I ran the specialist inpatient beds at the Royal Brisbane and Women's Hospital, which were the only public specialist beds in the state. And for more than 10 years, I've consulted as the director of Queensland Eating Disorder Service to every hospital in Queensland, so to about 20 different hospitals to support teams in general settings, managing inpatients both in medical and general mental health settings. And through that experience, I've come up with some principles that seem to be tried and true and helpful in managing eating disorders. More recently, I've had the pleasure of being medical director of Wandi Nerida, which is Australia's first residential program, but it is an inpatient private hospital with 13 beds. And very recently, I've been appointed to assist with the eating disorder program at New Farm Clinic. So the aim of any inpatient admission is to facilitate safety for a condition that has very high medical and psychiatric risks and hopefully recovery. ANZ, the Australian and New Zealand Academy for Eating Disorders, actually has a position statement on inpatient service for eating disorders. These were developed by a small committee that included myself, Dr. Sloan Madden, but also carer and consumer representatives. And I might just go through these principles to set the stage. Although the circumstances of individual patient services will differ, the following principles we thought, were important in considering the role of inpatient services for people with eating disorders. Most eating disorders can be treated in outpatient settings using the available evidence-based treatment. Inpatient treatment can still be required at times, however, for reasons of medical or psychiatric safety, or if outpatient treatment is ineffective. And I would add to that, if outpatient or day treatment is proving not intensive enough, inpatient treatment can be a helpful option. Number 3 is really important. Inpatient treatment needs to be part of a continuum of care and is not a standalone treatment for an eating disorder. The best outcomes for inpatient treatment occur when the goals of treatment are clearly negotiated from the outset of care between patients, their families, and clinicians. And I'll be talking a lot about the goal, what are we trying to achieve in an inpatient setting in the upcoming slides. And also discharge planning, what's going to happen to the person after the end of the admission should start from day 1 or before day 1. The age and developmental needs of the patient should always be taken into account. It is important that the treatment be provided in a person-centered and culturally informed way. And people with eating disorders and their families should have access to a continuum of care based on residential, day hospital, intensive outpatient, traditional outpatient, and guided self-help. The least restrictive treatment option to be used, but if the patient's decision-making is impaired, substituted decision-making legislation, including the Mental Health Act, should be considered. The best inpatient option is a specialist multidisciplinary unit. In the absence of available specialist beds, another option that has been used with some success, especially in public settings, is admission to a general medical or mental health bed with specialist consultation, liaison, and input. Wherever possible, carers need to be consulted, supported, and provided with the knowledge and skills they need to help their loved one during admission and following discharge. And I would add to that, the carers should be invited to all reviews if the patient is comfortable with that, because better decisions are made if we have everyone around the table working on the goals, but also the person is often discharged to their carers, and helps them immensely to be involved in treatment throughout. Inpatient clinicians should always consult with outpatient treatment providers prior to discharge. An effective collaboration is essential between medical, psychiatric, psychological, dietetic, and other services to ensure the various needs of the patients are met. So here we can see the consistency, good communication, coordination of care, and collaboration. All those C words are very important. And all specialist inpatient eating disorder services should evaluate and review their programs, including seeking feedback from consumers and carers about how to regularly improve those programs. The Royal Australian New Zealand College of Psychiatrists also has clinical practice guidelines for the treatment of eating disorders. And I commend these to you. They're quite practical and detailed in the section on anorexia nervosa in adults about the inpatient management. As many of you will know, it's mainly anorexia, but not only anorexia, that is the most common eating disorder we admit patients for treatment, and it has a high mortality rate. So one of our aims in inpatient treatment is definitely to reduce the risk of that mortality. And as you may also know, eating disorders are highly prevalent. About 1 million Australians have an eating disorder with a great cost to the community. Some of that cost is inpatient treatment, some of it's not being able to work or because of disability. And as you see there, there's a high death rate. Recently in Brisbane, the city in which I work, the local newspaper magazine conducted a story on the fact that during the COVID epidemic, there was a huge spike in eating disorders. So the public service I worked at, QEDS, had a doubling of their referrals from 60 a month to 120 a month during the COVID crisis, and that has not reduced in the last year and a half. In treating eating disorders, including the inpatient treatment, I find it really helpful to think about what actually causes, what causes a person to develop anorexia nervosa. So many of you might know what the cause of cirrhosis of the liver is, or the causes of hypertension or heart failure or stroke. But what causes anorexia? Well, we actually do know the biggest risk factors, but they're often not very well known amongst the community, including the medical community. But they include genetic factors. People with eating disorders are more likely to have certain personality types that are highly heritable, and these are obsessional personality types. So often people who develop anorexia are conscientious, obsessional, driven, similar personality types to doctors actually, and clinical psychologists and dietitians. So in a lot of the case, we're treating people with similar personality attributes to ourselves, attributes that are really valued in our society, but also put the increased risk of developing an eating disorder. Early attachment problems can lead to a lot of negative affect, and eating disorder behaviours can be ways to medicate or deal with feelings, or to deal with those negative intense feelings. So counting, exercising, dieting, all these things give a person a sense of control. And that's one of the reasons COVID has caused a spike in eating disorders, because everyone's feeling a bit out of control, and eating disorder behaviours are one of the ways we try and deal with feelings, and one of the ways we can try and get a sense of control. Obesity is a risk factor for anorexia because it leads to a higher risk of bullying and teasing. And of course, we have, with the advent of visual social media, especially Instagram and Snapchat, young children are being rated on their appearance and valuing themselves based on their appearance, and that's causing a real spike in dieting and eating disorders. Dieting is actually the biggest risk factor for anorexia. If you have 2 children and one goes on a diet, she's 18 times more likely to develop anorexia nervosa. And that is because dieting causes a neuropsychiatric syndrome called the starvation syndrome. What is the starvation syndrome? This is really important because actually one of the main goals of inpatient treatment, as I'll explain later, is to reverse the starvation syndrome, to reverse this neuropsychiatric syndrome. We know about the starvation syndrome from a study done in the 50s by Ansel Keys. It's called the Minnesota, well, it's informally called the Minnesota Semi-Starvation Study, but it's published in 2 large volumes as The Biology of Human Starvation. And what Professor Keys did was he got 36 men who were conscientious objectors to military service, to conscription, and they were signed up for a medical experiment in which Professor Keyes and his team put this, the experiment went for 1 year, and Professor Keyes got these 36 men and put them on rations so that they would lose 25% of their body weight. He observed them for 6 months and then he renourished them. But what he found was that 100% of these men, when they were starved, had profound changes in their thinking and their behaviour and their emotional states. They all became very obsessed with food, started to have a whole lot of rituals and rules and rigidity about how they would eat. They'd often eat very slowly, wanting to eat in complete silence, moving their food into particular shapes and arrangements before eating it. But they also developed what we call proofreader thinking, where their thinking was very detailed, and they lost the ability to go with the flow. Many of the men became depressed. 3 were admitted to the local psychiatric unit with suicidal ideation, and 1 chopped 3 of his fingers off. So it had a profound effect, and in fact it mimicked and is very similar to what we call anorexia nervosa. People being obsessed with food, not being able to eat, being focused on detail. And we find a lot of people with anorexia that, well, I find, that come through to my assessment clinic, well, quite well until they decide to lose a lot of body weight and develop obsessive thinking and rituals. And that reverses in more than 70% of cases with just renourishment of the brain. But it's very hard to do that as an outpatient, and sometimes you need to bring people in to renourish their brain. Which brings us to the 4, what I would say are the 4 goals of inpatient treatment. If we're going to bring somebody into a hospital, that's an expensive, possibly even traumatic treatment for them, very disruptive. And so we need to clearly explain to them, I think, and the team who's working with them and the family, what we're trying to achieve. So the 4 goals of inpatient treatment are, firstly, we want to stop the patient dying. So we often bring people into hospital when they're medically very fragile due to starvation and other eating disorder behaviours. Number 2, very important, we want to nourish the brain so it can benefit from therapy. Someone who's really starved can't benefit from CBTE. Thirdly, I think this is really important, we want to make sure that they can eat. We don't want to just feed them up and then discharge them. I would argue we need to give them trials of leave with their family to make sure they can eat adequately before they're discharged, and then link with outpatient treatment, which would include medical monitoring, but also evidence-based therapy such as CBTE. We might be stepping them down to another facility too, such as residential or day patient. In terms of keeping patients alive, well, to do this, we need to know what the risk factors are for sudden death. Most patients with anorexia feel not too bad, actually can feel great and have normal bloods just before sudden death due to arrhythmia. And that's certainly the most common way that I've seen patients die. It's hard to predict, and often they're found, in my experience, in bed in the morning, dead by their parents. It can be, I have seen it happen after a purge, but also just often their blood pressure or their glucose dropping. So it's helpful to know the best indicators of cardiac risk, and these coincide with the criteria for admission, whether that's admission to a medical or a psychiatric or a specialist inpatient unit. But if anyone's heart rate is getting low, below 50 or above 120, they should be admitted. There's always exceptions to these rules, but these are good guidelines to go with, and they're consistent with the College of Psychiatry guidelines. A postural tachycardia in a young person is often the first and sometimes only indicator of cardiac risk. So if their heart rate jumps up by more than 20 beats per minute, I would say in terms of the technique of assessing someone's heart rate and blood pressure, get them to lie down or sit, and then when you get them to stand, wait 2 minutes and then reassess the heart rate and blood pressure. If they've got hypertension with a blood pressure of less than 90, which means their heart's not getting enough fuel to pump blood to their brain. If they've got a postural drop in their blood pressure of greater than 20 millimeters. Now, normal blood tests don't mean the person is safe, but abnormal blood tests of these, in particular deficiencies in potassium, phosphate, magnesium, and glucose, indicate the person is very high risk. and they need to be admitted for nutrition. Prolonged QT, you can see on ECG with malnutrition, it reverses with nutrition. But of course, if you do have a prolonged QT, always check other medications that might be causing that as well, including many psychiatric medications. A BMI of less than 14, that level of starvation nearly always requires inpatient admission. If they're not eating anything, I mean, the most important criteria here, which I haven't listed actually, is a failure of outpatient or day patient treatment. We did mention that earlier. And if their purging's out of control, worth considering bringing in them into hospital to provide a stopgap to interrupt those behaviours. As well as stopping the patient dying, we don't want to kill them with refeeding syndrome. And probably all of you know about refeeding syndrome. But the important thing about refeeding syndrome is if you feed someone very aggressively, or they feed themselves very aggressively when they're in a starved state, on about day 4 or day 5 of that aggressive nutrition, they can get a precipitous drop in their serum phosphate, potassium, magnesium, glucose, or thiamine. And that can cause sudden death, heart failure, pulmonary edema, delirium. So true refeeding syndrome is rare, but we want to prevent it. The best way to prevent it is to be aware of it, especially in that first week of intensive refeeding, to have a gradual increase in nutrition from, we would recommend I'd recommend 6 megajoules, increasing by 2 megajoules every 2 days to 12 megajoules. That's consistent with the QEDS protocol, which has been adopted, or similar protocols in other states in New South Wales and Western Australia. Daily thiamine, parenteral thiamine for the first 3 days to prevent Wernicke's encephalopathy, and daily checks of phosphate, potassium, magnesium. Now, there are 2 different schools of thought. Some clinicians like to supplement the patient with phosphate, potassium, and magnesium. Other clinicians like me are happy to have it checked every day as long as replaced if it drops. The usual doses are phosphate Sandoz, 500 milligrams BD, potassium, 1 or 2 tablets BD, and magnesium, we use Magmin, usually 1 to 2 tablets BD as well. It's important to check blood sugars. If the patient's really frail and really low weight, I'd also add an O200 glucometer reading, because often blood sugars drop precipitously at night, and anything less than 4 would need to be replaced, 4 millimoles per litre, and daily ECGs initially. The way to treat nearly all medical complications of anorexia is with nutrition, and that's one of the benefits of inpatient treatment if they can get controlled, robust, supported, non-negotiable nutrition. That is the treatment for nearly all eating disorders. So neutropenia is commonly seen as a side effect of malnutrition, and the treatment for that is nourish the person, and that you would usually resolve with good nourishment within 1 or 2 weeks. Similarly to anemia, but you can also get anemias due to microdeficiencies such as B12 and folate. Raised LFTs are common with starvation, but you can also see them with refeeding. I've been told, but I've never actually used this, that one way to distinguish between rapidly rising liver enzymes due to starvation as opposed to refeeding is to do serial liver ultrasounds, and with refeeding, the liver keeps getting bigger. But I think they can usually be managed just clinically without doing ultrasounds, and usually if you just keep nourishing the person, those LFTs will settle. Amenorrhea is not a reason to admit people to hospital, but it's just helpful to inquire about amenorrhea for education to the patient who may think that they're putting on too much weight. And of course, bone mineral density scan can help to determine whether the person's getting osteopenia or osteoporosis. And the only treatment for that amenorrhea is weight restoration. Sorry, there's a typo there, but putting a person on the pill does not reduce the risk of osteoporosis. It just masks the problem. Constipation and other gastro discomforts are very common in people with eating disorders. But again, the treatment is I would normally use Movicol as a safe laxative as needed. Obviously, regular meals will help constipation. Look, I've put roughage there, but actually it's probably best to start with a low fiber diet initially because people's guts are very sensitive. Also, an abdo X-ray can be helpful to determine whether there actually is constipation. Often the person's not moving their bowels because they're not eating rather than being truly constipated. Sometimes patients get hyponatremia, which can be an indicator of they're having excess fluids, either intentionally or unintentionally. And most people with a BMI of 14 or 15 only need 1.5 litres of fluid a day and can be very sensitive to fluid overload. If they're a normal weight, 2 litres a day is enough, is adequate fluid. Okay, so initial medical management. Maybe I'll just take a step back. I find it really helpful to think about, when I'm thinking about the management of someone with anorexia in hospital, to think about 3 things: the medical management, the nutritional management, and the psychological management. And I'm doing all of those at once, or my team is. But obviously, in terms of priority, medical management is important. We don't want people to die or have serious medical complications or to have to be transferred to a medical ward. We'd like to avoid that if possible. So I've always put everyone on thiamine, as mentioned, order lying and standing blood pressure and heart rate, QID, monitor for refeeding syndrome, as mentioned, do daily bloods, replace anything that's low, and monitor for and treat hypoglycemia. I'm often asked about the role of medication. There's not much evidence for the role of medication, but I'll share how I do use medication with inpatients. This comes from the college guidelines on eating disorders, and in terms of specific pharmacological treatments, and I'll quote, "There is only weak evidence for pharmacological treatment of anorexia nervosa. Low-dose antipsychotics such as olanzapine may be useful in reducing anxiety and obsessive thinking, but results of trials are mixed, and such individuals are at greater risk of adverse side effects. Exercise caution in prescribing psychotropic medication for severe comorbid condition symptoms until it is clear that such symptoms are not secondary to starvation." So probably the most common problem I'm often asked to write medication by nursing staff, but because the patient is very distressed or anxious. Now, the best treatment for severe anxiety is exposure. So exposing the person to the thing they're afraid of, that is eating and weight changes. And after a while, their anxiety will diminish, especially as you reverse the effects of starvation syndrome. So I've always got that in mind, that is, in fact, the most effective treatment. And I'm also aware that prescribing medication, especially benzodiazepines, there's evidence that if you do that, they don't get the benefits of exposure. Having said that, for some people it's just too difficult, and obviously getting nourishment to their brain is the most powerful psychotropic thing. So if that can be helped by a small dose of, I tend to use oxazepam because it's a lot cheaper than olanzapine and it's much less likely to cause a prolonged QT interval or cardiotoxicity, which I'm concerned about with a lot of my patients. The idea that olanzapine helps by improving appetite, I think, misunderstands what anorexia is. It's not a loss of appetite. It's often that having an appetite can be very frightening for them if that's artificially increased. So I'm a bit of an olanzo skeptic. I tend to use small doses of oxazepam, and the doses I'd use would be like you use with a little old lady, because these are frail medical patients. Even though they look young and healthy-ish, they're in starvation. So I might use 7.5 to 15 milligrams QID oxazepam, always warning the patient about the risks of dependence and tolerance. Sometimes use quetiapine in low doses, say 25 milligrams PRN or before meals. Patients do find that helpful. As for antidepressants, there's good evidence that they don't work on starved brains. Antidepressants with people with low body weight have about a 35% effectiveness, which is similar to placebo. So antidepressants plus nutrition works much better. Okay, so the heart of treatment is nutrition. And, when I started eating disorders, I really could not think in calories or megajoules. And I've learned so much of my dietetic colleagues over the years, and I will try and share what I've learned in a simple way. Really, remember, this is, if you're treating schizophrenia, getting the right dose of risperidone is how you reverse the psychosis. If you're treating anorexia, getting the right dose of nutrition to the brain every day over a few weeks is how you're going to reverse brain starvation and have a patient that's much less terrified and much less rigid. So after studying thiamine, I wouldn't delay putting them on a 6 megajoule meal plan, or that's equivalent to 1,500 calories. Now, that is a light diet. So that's like having sandwiches for lunch, a couple of Weet-Bix for breakfast, and a normal meal for dinner. It's not a big, at 6 megajoules, the patient will stay, if their BMI is 14, they'll just stay at BMI 14 forever. And if they're medically unstable, they'll stay medically unstable. So we just start at low to prevent repeating syndrome, but we really want to get up to 12 megajoules within a week. So every 2 days, we increase by 2 megajoules to get to 12 megajoules. And that is a fair bit of nutrition. That's more than you would eat in a day. Probably you're eating 8 to 10 yourself. And so to make that easier for the patient, we often use supplements. So if they're in medical ward, we give all that nutrition by nasogastric feeds. If you've got them in, in your specialist eating disorder unit, Ramsay unit, the way I would probably like to go is what's called a 3-step plan, where the dietitian writes up the meal plan, which is starting at 6 megajoules, but going up by 2 megajoules until it's up to 12. And they're offered the food. If they can't eat 100% of the food, which within the prescribed time, they're asked to drink a supplement. Okay, and they'll be written up by the dietitian. And if they can't drink the supplement, they'll be put down the tube. And I would make that non-negotiable for them being in hospital, that they have that treatment. Because it's like, you can't treat mania without giving someone lithium or whatever medication you're using. You can't treat anorexia just by counselling. You've got to get that brain renourished. And so in psychiatric wards, we tend to use what's called a 3-step plan. In medical wards, continuous nasogastric feeding. But you can combine those. So you could have someone on a 6 megajoule oral plan through the day, so a light diet of 3 meals, and then overnight have 6 megajoules in the nasogastric. That's one option. But I like to get people eating, and even if half that nutrition is due from supplements such as resource, they can then transfer that to home. People can go home on food and resource drinks. It's very hard for them to go home on nasogastric feeding. Before I get to assessing weight, I would say that I think generally as clinicians, we put too much emphasis on weight in assessing a person's progress and how sick they are. And I'd really encourage you to use other parameters. And so, somebody can be a BMI of 40 and they can lose 25% of their body weight and still get very medically unstable. So they'll still be overweight, but they're malnourished. So, someone with a BMI of 29 can be very sick. And I think a better way to assess weight, assess nutrition, is to actually look at what nutrition they're getting, to document that and to make sure they are getting it and over what time period. So how much, I'd like someone on 12 megajoules for a few weeks before if they are getting that and we're sure they're not purging or over-exercising, well then, and their weight hasn't changed, I wouldn't be too worried. If they've had massive weight changes in the first week, but we know they're not eating, it doesn't really mean anything. Anyway, having said that, use the same scales every time, just weigh a person twice a week, empty their pockets, no shoes, check no weights attached. If there's sodium chloride or osmolality below normal range, I would tend to think they're water loaded and I'd ignore the weight, say it's an invalid weight. Plot the weight on a graph and only report meaningful changes in weight. So I'm a big fan of BMI banding as developed by dietitian Shane Jeffrey, Queensland dietitian, which looks at only significant changes in weight. Because if you step on the scales every day or even twice a day, you'll notice changes in your weight based on bowel motions, fluid intake, humidity, different scales. They're meaningless. So don't overinterpret those weights. A BMI band is about 2 or 3 kilograms. So if someone's put on 2 or 3 kilograms or lost 2 or 3 kilograms, that is significant. And also, as I said, look at all those other things like neutrophils, heart rate, blood pressure, temperature, menstruation, brain function. That'll give you a better idea of how their nourishment is. So as we've mentioned many times, but it's so important, starvation impairs brain functioning, affecting a person's reasoning, judgment, and decision-making capacity. We know this thanks to the Minnesota semi-starvation study, as well as observations in eating disorders units. I've literally seen hundreds of people recover from starvation. And restoration of normal weight sometimes cures the anorexia and nearly always significantly improves their ability to benefit from therapy. Here's an example of how I use BMI banding. So if we just use kilograms, here's a patient who has been 9 weeks in hospital. They've actually been in a medical ward. And as you can see from that graph, which is in kilograms, they seem to be slowly making progress. But if we change the y-axis from kilograms to BMI, we'll see actually that, gee, this is a very sick person. The BMI is in the 11s and 12s, but they do still seem to be making slow progress. If we use BMI banding, which I haven't actually gone through in detail, BMI banding involves only saying the person's put on weight if they've recorded 2 consecutive weights in a higher BMI band or in a lower one. If we do BMI banding on this patient, this is their actual progress, I would argue, in 9 weeks. They actually haven't improved at all. They stayed in a BMI of 11 or thereabouts. They had one reading in 12.1, but it really, the changes have been the sort of changes you would see normally with chance or with natural fluctuations. So BMI banding is a much better indicator of progress. The other benefit of BMI banding is if someone come into hospital at BMI 13 and you discharge them at BMI 17, they only experience 4 weight changes in the whole admission, which might take 2 or 3 months. Whereas if you're telling them their weight in kilograms twice a week, they will be they'll be distressed by any information about weight is distressing to a person with anorexia, but also the whole team will start to believe they're making progress and think they're going backwards and maybe bring in changes in the patient's treatment when they're really not founded. But if we use BMI banding here, by about week 3, you should go over BMI band every 3 other weeks. If nothing's happened by week 3, we'd be thinking about changing their feeds or supervising them in toilets or bathrooms to making sure they're not exercising. And by week 4, we'd definitely be doing something different. We'd put it up to 40 megajoules probably. Nursing management is the cornerstone of inpatient management of eating disorders. And so it's very important we support our nursing staff, but also give them very clear guidelines and protocols so that the nurses like to know exactly what their input should be, but also helps them to know the rationale. So the patient needs, and it doesn't help to talk about the patient as being difficult. Anorexia is difficult, but patient's got an illness. And so we need to support them during and after meals so that anorexia doesn't tempt them to interfere with food or to purge or to exercise. And we would say no leave off the ward initially. I've been advised at Newfound Clinic, normally first 2 weeks, no leave, and I would support that. Clearly, the nursing staff need to take OBS and notify of any abnormality in OBS or BSLs, do a daily ECG, and support the patient to prevent them engaging in eating disorder behaviours, as well as weighing them twice a week. This is something that's been used at the Royal Brisbane and developed over many years with consumers having input into it. And I found this one-page document extremely helpful in managing, or in ensuring rapid progress in patients with eating disorders. And what this is, in a nutshell, is very clear, transparent criteria for when a person can have increasing periods of leave. And first of all, they need to be medically stable. Secondly, they need to be nourishing or eating all their food or having all their nourishment in hospital. They need to be not engaging in compensatory behaviours, participating in the group program. And then you'll see the leave is increased, and leave is always an opportunity to eat off the ward and demonstrate you can eat, ideally in the presence of loved ones or maybe even the staff member. It's not an opportunity to go shopping or to do exercise, because leave is an opportunity for the patient to demonstrate to themselves and their family and to you that they're ready for discharge. And so we normally start with just one snack. They might just take that snack off the ward to make it easy. Then they might go progress to leave a snack and a meal, and then a 24-hour leave period. And once if they come back after 24 hours and they and their family say they are really eating well, they're drinking the supplements, then you can transition to the next treatment. And you'll see along the bottom there, we've actually got, this is with the Royal Britain, it's a public guideline, if the person's not progressing and their BMI hasn't increased after 3 weeks or even 4 weeks, we would reduce the leave or increase the nutrition or supervise toilets and showers or transfer to a more higher monitoring environment with locked toilets, for example. When we implemented this, it slashed our length of stay, where people were staying for 9 months and just going nowhere to an average length of stay of 8 weeks. Inpatient treatment is very stressful. You don't want to prolong that by being lax and inconsistent and prolonging their admission. And I've had a lot of consumers who've recovered say the worst thing for them when they went into hospital was when there was inconsistently and they were allowed to exercise or purge, even though they couldn't help doing it. It really distressed them being allowed to do that because of a loose program. So I don't think programs should be punitive or too detailed, but I think they should support 100% adequate nutrition so the person recovers quickly. Now, psychotherapy, people in hospital do need psychotherapy. Often they're not very good at engaging in formal psychotherapies like CBTE because their brains are a bit malnourished and they're quite distressed about the nourishment. But all these sort of approaches can be helpful for people who are not formally ready and willing even to engage in psychotherapy. Motivational interviewing. If someone wants to leave hospital, talking about the pros and cons of that. If they want to hold on to their eating disorder, the pros and cons. Education about not only starvation syndrome, but also the effects of starvation on the brain, but the effects of starvation on all the other organs of the body. A narrative approach where we externalize the eating disorder as separate from the person can be very helpful. Enlisting the family in decisions. Often when a patient doesn't want to eat, the family can be helpful and encourage them to eat, especially on leave. Having behavioural contingencies. So, for example, if someone is found to be exercising and purging, the leave will be stopped till the next review by the consultant. Having a team that are all on the same page is very powerful and very effective for someone with anorexia. If the team is divided, that just feeds the anorexia. But we're also trying to gradually, again, we need nourishment to do this, to shift the patient's concrete thinking. Concrete thinking includes things like, I'm fat, my numbers are okay, to metaphorical thinking, well, how's your relationship with yourself going? How are you going with coping with feelings? Are you better at feeling feelings rather than try to suppress them through eating disorder behaviours? Okay, so you're the psychiatrist, but you've got a team there of nursing staff, dietitian, psychologists, other allied health. It's all important you're all on the same page with what's happening with medical monitoring, with management of eating disorder behaviours, with nutrition, with leave. But yeah, we need a team to be all on the same page. In a way, inpatient treatment of an adult in an eating disorder unit is like family-based treatment of an adolescent. The parents or the clinicians need to be in charge, and they need to be supporting the person against the eating disorder. An effective team, think about what qualities does an effective team have. If you had anorexia and you're admitted to your local Ramsay unit, what would you like the team, what qualities would you like them to have? You'd like them to be consistent, transparent, safe, authoritative, not easily manipulated by your anorexia, caring, non-judgmental, responsive, reflective, open-minded. Okay. And, we need the Chatham House rules, which are used in cabinet. And that is that although we might have some disagreements in the team meeting, whatever consensus and decisions we come to, that's what's presented to the patient, whether you personally agree or not. Another thing I find helpful in inpatient management is that as well as the clinical ward rounds or the clinical reviews where we need to get the team working, making decisions about the person's nutrition and their leave, I often find they're the two levers you're working on to help a person get better is nutrition and leave, and maybe support around toilets and bathrooms. But you also want the whole milieu to be consistent, for the staff to feel supported, for there to be good morale, to have a learning team. And so I think it's helpful to have business meetings where key people in the team meet together to look at how they can address cracks in the program, because a group of people with anorexia will always show up the cracks and put wedges in the cracks in the program. And it's important to have regular planning days to recalibrate the program. And ideally, I think it's good to have consumers and carers come and share their experiences of inpatient treatment and recovery to inspire, especially the nursing staff. It's important to remember the nursing staff often only see people when they're really sick in hospital, whereas you might well see your patients in hospital and out of hospital. And out of hospital, they're often a lot better. And so to bring our patients in to speak to nursing staff or to have consumers who've recovered talking to nursing staff is one of the most helpful ways to improve morale. Psychodynamics. I found this textbook, it's a very old one now, extremely helpful, but it talks about the psychodynamics of inpatient management of anorexia in one of its chapters. And I learned this way back as a registrar, this idea that every patient with anorexia nervosa is internally divided. Part of them just wants to lose weight, another part of them wants you to help them to stay well. And they project that internal division, that ambivalence onto the team. So without a psychodynamically aware team, what often happens is half the team think, well, we're being too tough on her, we need to give her some freedom. And the other team think, she's manipulating us, we need to come down hard. And that really is just a manifestation of the patient's internal division. And you can see that projected into the poor family too when they're trying to manage. That's why FBT works so well with adolescents. But the team becomes divided. And so I think it's important at all team meetings that we hear from each of the team members, their counter-transference, their feelings and thoughts, and then come up with a consensus plan. Counter-transference, is data. If you're feeling really anxious about a patient, they're probably feeling very anxious. If you're feeling frustrated and annoyed with them, they're probably feeling angry about stuff. So it can be helpful to say, I get the sense you're feeling really frustrated with aspects of being here. What is it that's really you're finding hard? And if you're feeling powerless or incompetent or worried you're going to be blamed, or damned if you do, damned if you don't, these are all common counter-transferences which reflect what the patient is feeling and needs help to be able to voice. Okay, let's just have a little think. Just looking at time, we've got another 15 minutes or so. Alex is a week into an admission in your hospital under your care, and she's observed the nursing staff tell you to be doing star jumps beside his bed and behind closed curtains. You approach the bedside and ask to pull the curtains back. Alex initially resists and states he just needs to finish the 500 jumps. Well, that's what the nursing staff have told you anyway. That's what they're dealing with. Any thoughts on how you would manage that? Well, remember we use the terms non-judgmental, supportive, but also authoritative, trying to protect a patient from their harmful eating disorder behaviours. I think the first thing I'd do is I would want to hear from all the staff about the problem, just to see something they observe. I'd also want to look at it in the context of how they're going medically. I'd expect medically they're not going well if they're burning off all that energy. I want to know what nutrition plan we've got them on. So even if they're on a week into the admission, they probably just started at 6 megajoules and been up to 12 megajoules within a week. But I'd be looking at what's happening with their blood pressure, their heart rate, their neutrophils, their blood sugars. And if any of those are problematic, I'd certainly be talking to Alex about that and saying, are you aware that with your blood pressure and your heart rate and your glucose, you're at risk of actually dying, suddenly dying when you're doing those exercises? And he may not want to die. And I'd probably have his parents in the room too, so they hear that. I'd want to increase everyone's anxiety about the risks of exercise. Because in the patient's mind, often exercise is healthy. Clearly, it might not be in this case. And I'd say we need to protect you from the eating disorder killing you. And so we're going to insist that you have the curtains back on your bed and have you in a bed close to the nursing station. We're also going to supervise you in the toilets and bathrooms until you're medically stable and we can see you've got the exercise under control. Also, we won't be able to give you any leave until that exercise has reduced significantly, because we don't want you're dropping dead on leave. All of those things together, in my experience, always help to reduce exercise. And a little thing I find helpful to tell myself is that I can't control other people. I can only control my behavior. And my behavior and the team's behavior is how they're responding to the exercise. So you certainly wouldn't give anyone leave who's engaging that level. And you'd also say to them, look, if you don't feel you can reduce it, we might need to increase your meal plan. And that often causes great terror. So would you prefer to increase the meal plan now, or give yourself a week to see if you can reduce exercise? And if you can, we won't increase the meal plan. Patients often say, no, I'd like the chance to not have the meal plan increased. When I say increased, often we go to 14 megajoules if someone's really burning a lot of energy, rather than 12. I mentioned family engagement. I think involving families, seeing them as allies, obviously not blaming them or being critical, but really involving them in your assessment of medical risk, your reasons for nutrition. Often the patient's eating disorder is imploring the family to let you be softer on the eating disorder. And if there's a lot of disturbance in family function, or even if there's not, family therapy can be helpful with adults, as long as it's family therapy for people with a bit of experience in eating disorders. Okay, so we're going to wrap up soon, but one thing about anorexia, it has this, and people with starved brains, they get this very fine, detailed, what I call proofreader thinking, and they have a tendency to complicate everything. And there's a lot of emotion, and there's a lot of ambivalence, and there's a lot of fear. So I find it helpful just to pan out and always keep the big picture in mind. And really, I'm only trying to do usually one of 4 things. And how am I progressing those goals? This is like a standing agenda every time I review a patient, either on my own or with the team who's in hospital. Firstly, how are we progressing with their medical stabilization? Are we making progress? Secondly, are we reversing starvation syndrome? Are we giving them adequate nutrition? Is it staying in their body? Is their brain getting better? Thirdly, are we safe yet to progress to the trials of feeding themselves off the ward? And fourthly, and to think about this from the beginning, will they have adequate support when they leave here in terms of medical monitoring, including evidence-based specialist psychotherapy to help them once you've renourished their brain? And they may well need an outpatient dietitian or a day program, a residential program for more support. It's very hard to go from 168 hours of support a week to 1 session with a psychologist a week. That's why I like gradual transitions to the next level down. And talking to the patient about this and saying, I don't want to set you up to fail, I want to set you up to succeed. Do you feel confident if we leave next week that you'll be able to eat 3 meals and 3 snacks a day, including the 3 supplements we've prescribed for you? And to assess that confidence, I often say, okay, you're planning to leave Wednesday. Take me through what you're going to do within 2 hours of leaving in terms of morning tea. Where are you going to eat? What are you going to eat? And if you see them get frightened or dismissive, they're not ready for discharge. But as I said, you will have had trials of eating anyway off the ward. Okay. Sorry, just had a little problem with the slides. Apologies for this. At the end, but yeah, we are. Thank you for your time.